Good morning. Thanks for joining us. This is Ed Fry, president of ACC, and thank you for participating in this segment of ACC UnEDited. Really a pleasure today to be coming to you from the CV Summit here in Washington, and I'm joined by my partner in crime, Cathie Biga, who you all know, who is CEO of Cardiac Management of Illinois, but most importantly to you is the former board chair for MedAxiom, trustee of the college, and soon to be vice president, incoming president of ACC. Also joining us is Dr. Paul Casale. Paul, longtime friend, also ACC trustee, and long tenure in being involved in the college's efforts around quality payment programs, population health, and health system strategies. Paul is in New York at New York Presbyterian. And also joining us, and it's a great pleasure to have Dan Blumenthal with us. Dan is the founder and CEO of NovaCardia, which is a technology-enabled cardiology-focused specialty MSO, a really interesting concept in this space and topic that we're going to talk about today. He is also a practicing non-invasive cardiologist at Harvard Medical School and Mass General Hospital. So Paul and Dan, great to have you with us here today. So the format of this program, the sessions that we've had in the past have been really focused on having a dialogue and interaction. There is the ability of audience members to put in questions in the chat box. We're going to have a conversation, and then we will try to get you your questions in the chat box as we go along, either during the conversation or certainly at the end. So just to the topic that we're really delving into today is value-based care and what that really means, and what are the changes that are taking place around us to, number one, have us focused on value-based care. What are the things that are happening in our profession, both in cardiology and more broadly in medicine, to meet the goals of value-based care? And so I think it's a good place to start off to say, so what, outside of cost or quality over cost, what is value in healthcare? What does value really mean in healthcare? Dan, maybe you could start us off with how you think about it. What's your definition?
Yeah, I mean, it's a great question, Ed, and I think you know that you laid out the initial kind of the technical definition, right, which is quality per unit cost achieved, and really the I think the concept underlying value is that we should, when anybody pays for anything, right, whether in healthcare, there should be some definable outcome that we're trying to achieve, clinical outcome, or outcome for the patient that we're trying to achieve with that incremental spending. And the way that I think about it is really it's about delivering the right care in the right place at the right time, right, and for the right price, which is the quadruple aim. And there are lots of ways to improve the value of care, and I'm excited to kind of continue to talk about those with this group today.
Paul, you both within your system, you think about these things, but you also think about these things on behalf of the college and have built programs around it. How would you define quality outside of that standard definition? Or I'm sorry, define value outside of the traditional definition?
I'll just add to Dan's comments, which I think were terrific. I think in my thinking around this, I think when we think of quality, we really need to focus on outcomes. I think quality is, we think of a lot of things that are often sort of the process measures. We've gotten more sophisticated over time, and I think as it's matured, we really need to focus on specifically around outcomes. And I think when we think about value, also, I think it has to be rooted in the experience of the patient and in the experience of the clinician. And I guess the other thing I'd say is, when we think about value, it depends on the perspective, right? From the patient's point of view, it may be around access to care and affordability. For the clinicians, it's, really focusing on the quality of care, and as Dan said, the right care at the right time for the right patient. And the payers are often just focused on costs. I know we'll be talking about that, but they don't, they often turn to cost first when they think about value. And the employer's probably thinking mostly around price for quality. So again, I think depending on the perspective, also plays into how one thinks about value.
So you alluded to that we've had really surrogate measures of quality in the past, and not so much outcomes. And is that because it's just difficult to measure those, or we don't have good tools to measure them, or is it a little bit like pornography? It's hard to describe, but when you see it, you know what it is. I mean, not that we know anything about that, of course, but I mean, why do we have a time struggling with outcomes?
Yeah. It's a great question. I think I think all of the above in terms of what you just described. I think, well, first of all, when you think about quality, we often have to think of who's accountable for the quality, right? So
Right.
at what level?
That's right.
And often people reflexively go to we want it at the clinician level. Well, at the clinician level, then we often get into the process measures, which may, in fact, some of that can be accountable to the clinician. But when you talk about an outcome, it really needs to be at a higher level of accountability, because it's really, again, we'll probably talk about this more around, it's the team-based care, and it's really at a broader level. And I think we struggle with that when we talk about, well, what outcomes should we be measuring and who's accountable? And I think that in the short term, the process measures have just been sort of easier to get data around. I think the outcomes just generally have been, well, first, what are the agreed upon outcomes? And then how are we going to capture that data?
Definition's clearly important. Cathie, I'm going to ask you the same thing. I mean, you've worn many hats from a slightly different perspective, managing physician groups, being a CEO of a hospital, being an administrator. How do you think people from looking at it from those perspectives are looking at it differently in terms of what quality, or I'm sorry, again, value means to them?
I think it is a little bit different, but I'm not sure that I can improve much on what Dan and Paul said. I think our biggest issue is appropriate data and how you can actually pull outcomes, because process data and outcome measures that Paul's talking about isn't what we need. And if it's not in a structural field, it becomes almost impossible to identify unless you exert a lot of human resources. And so I think in our healthcare systems, that value equation is shifting and needs to shift. It needs to become much more patient-centered. We need patient-reported outcomes. We don't really need to consistently look at just clinical outcomes. Well, how does the patient really feel, and define value that way? I think the second thing that is something we tend to overlook when we're talking about value is operational efficiency. No matter how we do this, there is still an enormous amount of waste in our system. And we really can't get to a value base. We always compare it to money and how we get paid, and it needs to go beyond that. It needs to go beyond how we are delivering care to our patients with a CV team approach and in those operational efficiencies.
Yeah. Well, I think that's a great segue into then posing the question, clearly quality and cost are interlinked and in many ways interdependent, yet we have seen approaches in terms of trying to get to value of manipulating one in favor of the other, whether it is to ratchet down cost, provided that we maintain a threshold level of quality. And then we've seen organizations that say pushing quality, cost savings will inherently flow from that. Is that the right way to think about it, or is that are those concepts true? I suppose it's probably a little bit of both, but Dan, in your work, where would you see the balance sort of settling out?
Yeah, I mean, I think as with many things, Ed, the truth lies somewhere in the middle, right? First, I think quality is paramount, right? I mean, as healthcare providers, right, we need to remain focused on, and leaders, we need to remain focused on doing what is right clinically for the patient. That being said, there is a lot of opportunity to do the right thing for the patient, and in doing so, improve how we spend money on those right things. The too much of a focus on cost, right, and an avoidance of focus on quality is certainly a warranted concern. And so you have to kind of keep both in focus. And I think, I think Cathie alluded to the opportunity to reduce administrative waste. There's been a lot of work on that, done, not just published work, but also a lot of work within the National Academies of Medicine and at CMS done on focusing on ways to reduce administrative waste. There's a lot of opportunity to improve where care is delivered, right? To reduce costs, maintain quality just by moving care from a higher cost site to a lower cost site. Better prevention is another big opportunity, and and then doing the things that we know. I mean, one of the beautiful things about cardiology, and one of the reasons why I love cardiology as a clinician, and what drew me to cardiology, is that we have more evidence to guide clinical decision making than I think virtually any other specialty that exists. In fact, I think I'm pretty confident we have more than any other specialty, and we in general know many times what the right thing to do is, and we have to contextualize that with with specific patients in mind and have those shared decision-making conversations. But continuing to ensure that we do that consistently is hugely important for driving value. There are some things, there are a lot of things I think that we can do in cardiology that improve quality and increase costs. And those interventions, those services are still of great value to patients, as long as we're kind of in agreement on what the acceptable incremental cost is when we're doing those things. And that's one thing I think that we struggle with in this country, right? Is a belief that or a lack of a consensus around what we're willing to spend to incrementally improve quality. And I think there is a lot of work still to be done there as well.
So those are great points, and I think it's a relatively new concept for clinicians to incorporate the concept of cost and certainly value in their clinical decision making and choices. Paul, we have a in cardiology, as Dan alluded to, we have a luxury of data. We have a lot of data, and even in our clinical registries that we're familiar with, but we also have all sorts of large data sets, especially through health systems and things like that. But what kind of data or what pieces of data are going to be most important in making these value types of decisions in clinical care to really achieve optimal cost effectiveness and optimal outcomes and to hit that balance? What type of information do we have? What type of information do we have available to us currently, and what type of information will we really need to get in the future to make those appropriate decisions?
Yeah, it's a great question. I think we still struggle with the siloed data currently. I would say it's very difficult, at least in my experience, to get to sort of the true cost of care. We often use utilization as a surrogate, and that has its own set of challenges. I can say that, the work that I do here at New York Presbyterian, what I'm often trying to do is link the claims data, which again, it's a surrogate, right? It's utilization data. It's not true cost data. But linking that, we're in Epic, so with our EHR data, where we can get a richer understanding of the clinical care that's being delivered, across the system, both inpatient, outpatient. whether through primary care, cardiology, and together, to try to get a better sense. That's not perfect. I mean, I think it's kind of what we, at least what I see we have currently. But even with that, again, in the metropolitan New York area, for my patients that are attributed to us, half of their care is outside our system. You know, again, it's not just in New York City. I mean, that's not uncommon that patients go to lots of different places. So I bring that up to say that we need better links around data more broadly, so that when the clinician is seeing the patient, they really have all that information at hand to help really assist with the decision making. So I think that really, from an ideal point of view, would be to be able to get that collective data across wherever the patient is being seen. If we can get to true cost data, I think that's helpful. In the meantime, I think utilization is okay, but ultimately, I think we do need, the actual true cost data. I think we're still far away currently, to be honest with you, before we actually have that information.
Pretty elusive, certainly, in all of our systems. So Cathie, at the summit that's just wrapped up this morning, we heard a lot in the 2.5 days here about the impact of the workforce crisis and how that's impacting our clinical teams and our well-being and our efficiencies and driving up costs. Do you see a shift to a value-based system as part of the solution to the workforce crisis, or could it compound the workforce crisis? How do you see those two things interacting?
Well, I don't see them interacting, to be perfectly honest. And I think the quagmire that we have ourselves in is that we talk about value. We've talked about all these things. The bottom line is we have to start innovating. We have to start doing things differently than we've done. We cannot continue to deliver care the same way that we have been delivering it. And to Paul's point, we need to know what it costs us. I don't know that I could find a decent cost accounting process anywhere in the country that can truly tell me at the physician level, at the provider level, what things are going to cost. So we know the workforce shortage is costing us a lot of money. I mean, we know that. So what are the unintended consequences of that from an outcome perspective? You have your cath lab maybe fully staffed by either travelers or agency. You've got your floor nurses that are extended beyond belief. You've got ORs that have to close because we don't have enough individuals. So now, one of several things are going to happen. Our patients, much like during the pandemic, will come back to us sicker because the access has been shut off. So how does that? It hurts value, because the outcomes are absolutely going to be impacted. And so I think the challenge at the summit the last couple of days is we got to stop talking about it and we have to start doing something about it. We have to get our teams actively engaged and do it differently. And if we walk into an exam room that continues to look like our 1960 exam room, we're not doing anything different. We need some of AMI's EKGs that can help us predict in order to get to that future that we really need. So I think it's a great question, but I think when you're looking at value, you've got to wrap it all together and you've got to get data. I'm so tired of telling my physicians, you've got to document how sick your patients are, but I can't get their risk score. You wouldn't know what your risk score was because we can't get it. So how can I help you get to where we need to go in a value-based world if I can't even get you the data?
Well, maybe Dan's going to solve that problem
Cool.
for us, and from the tech-enabled, innovative standpoint. And how can technology and innovation perhaps address some of those concerns?
Well, I mean, I think to Cathie's point about risk scores, most EHRs are now configured to facilitate risk adjustment coding, right? I mean, this is to be perfectly frank, this is big business, right? There are billions and billions and billions of dollars at risk here, and EHR vendors know that, and so Epic, Athena, Cerner, they all are configured to help facilitate, right, appropriate coding of patients in a way that ensures that Medicare. I mean, many of our patients now are 70% of our patients are Medicare beneficiaries, right? On average, if you look nationally across the country, right now we're at about 40, upwards of 4 in 10 of those are Medicare Advantage beneficiaries, and MA runs on risk adjustment. And so do ACOs, which account for a quarter of the remainder of our Medicare patients. By 2030, CMS has said all Medicare patients should be in either MA or accountable care organization. So we have to prepare for that world. And that fundamentally involves understanding how Medicare is showing us, right, the way in which it's going to risk adjust spending on those patients. And that, as far as I'm aware, remains the prevailing mechanism by which Medicare intends to risk adjust payments. So those tools exist at the point of care already. I think cardiology and many other specialties have not been at the forefront of figuring out how to use them, because primary care has been the mechanism by which Medicare Advantage and ACOs have sought to partner around vertical integration, right, between payers and providers. I know this because I was part of a Medicare Advantage health plan. I helped start and build one. And I spent 2.5 years there as the associate chief medical officer and the national medical director for the health plan. I was at Devoted Health before I founded Novocardia. I was in charge of risk adjustment and understanding it, and understanding HCC coding and how that impacted risk adjustment. So this is something that I understand very well, and I don't think the average cardiologist really has any idea of what the implications of appropriate coding are for total spending on patients and also for reimbursement, right? So there's some basic education that needs to occur, and then figuring out how to ensure that if cardiologists are actually participating actively in that work, that there is some reward flowing to them for creating the value that, and I'm not talking about value for patients, I'm talking purely about financial remuneration in a world where that's where payment models are heading, right? That cardiologists are actually actively engaged in participating, not just in the work that needs to be done, but also sharing in the value that gets created, financial value that gets created, and then doing the right things for patients, right? In order to align the care that they deliver with the goals of payment reform, which are to deliver better care at lower cost, right? Keep people out of hospitals if they don't need to be there, and deliver more prevention-focused care. And I think that I just think that there's a tremendous amount of opportunity to educate cardiologists about how to use the tools that already exist, right? I do think that there is some transformation in terms of new innovation that needs to take place, but there's also just a lot of adoption of what's out there that needs to happen.
You touched on a lot of very important concepts, and one of which the primary care piece, which I'd like to come back to in a little bit, but perhaps to follow on to your last set of comments around sort of the incentive piece and the aligning the incentives and whether that is manifest through compensation or other incentives. So obviously that this transition, and if it really is the holy grail to get to 100% of Medicare enrollees to be in some value-based system by the end of the decade, that's not very long from now, yet it's not going to happen overnight. It's not going to happen very fast either. Paul, what kind of things do you see being incentives that are created for not just the physician, but also other important parts of the care team, incentives being put in place to help them drive them in that direction?
Yeah, great question. So I think as we all know, we're still very much in a fee-for-service world. And so incentives are still very much focused around fee-for-service, talking about the specialists in particular. And to the points Dan was making and you were just making now, Ed, creating incentives with clear financial benefit is going to be important, because as Cathie said, we need to take care of patients differently. It's going to be critical, right? I mean, the clinician workforce is shrinking, the number of patients is growing, but all of that requires, financial support to build teams, to do the digital and remote work, to have the data infrastructure, all of those things. And fee-for-service it clearly doesn't support that. So I think we are still looking to CMS and other payers to create ways for specialists to get the financial benefits. So whether that's around, the creating episodes of care or chronic condition management or some other payment to the specialists, I think we're still trying to sort this out so that the specialists understand or see a pathway from fee-for-service to, a financially viable alternative within value-based care. And I don't think still don't see it yet, but CMS is declaring 2030. Again, I don't want to just focus on CMS, but they're going to need to put those things in place, in order to engage the specialists more fully and seeing a path forward in this move from fee-for-service to, value-based care.
There may well need to be subsidies to basically allow that transition to take place. Cathie, and you have a broad view, being immersed into large healthcare systems. We're obviously very cardiology centric here. The world revolves around cardiology, and obviously we're a big chunk of total healthcare spend and delivery of services. But when we talk about value, we're really talking about it across the spectrum of true health care and taking care of people over long periods of time, the arc of their life. And so how do you see sort of instituting those kinds of payment reforms inside of a broader value approach? Is it going to be that perhaps subspecialties will still operate in a type of fee-for-service kind of arrangement inside the umbrella of a broader value program? Or will it be a share of, say, the per member per month premium? Or will it be, will we, have bundles that, will be sort of cost adjusted and priced inside of that kind of arrangement? How do you see that working out?
Thanks for the simple question. Appreciate that. And I think the reality is, as Paul mentioned, is we're starting to see a little bit of change in aligning incentives. We've seen Stark start to back off. And if you're involved in value-based compensation, you've got a few more latitudes that you can actually use, because the honest answer, and you know me, the honest answer is that physician compensation is going to be driven by the model of care that we deliver. So the bottom line, and if you're going to get that buy-in, you've got to understand how those three legs of the stool come together, because otherwise it's just going to be fought sort of tooth and nail. The other part of your question, which I think is spot on, is in our large systems and such, I cannot tell you the number of primary care patients that we are now seeing. Hypertension appointments through the roof, diabetes through the roof. If you've looked at your MIPS cost data, the latest cost episodes that have come out, I said, nah, there's no way that we've been attributed a bunch of lives. I don't really need to look at it. Well, you know me, I went to look at it, and we've got several thousand patients attributed to us as a pure cardiology tax ID. And I'm thinking, for what? I had so many, well, not that depression is anything to smile about, but we had so many depression patients, because that was one of the other bundles that came through in MIPS this time around. And it really forces you to start to look to see why are we getting attributed these patients, number one, but how are we caring for them? And so that's when you ask how it's going to change, my own personal opinion is we need something prospective. We keep doing this retrospective look back. If I don't do something prospective, I'm not going to change the way you deliver healthcare. And if I have a prospective model in place, that's what'll start to change it, because the patient's going to be in the center. We're going to really use guideline-driven care and drive to those outcomes. That to me is the only way it's going to change, because we keep mandatory bundles. You do this, you do that. They're just little pieces of the puzzle, and as we know, it's broke.
So it sounds a little bit like the handing off of the patients goes back to the Samuel Shem book, The House of God, the buffing and turfing, right? So there's a little bit of that going on. Dan, how do you see, or how do you envision the role of primary care and the relationship between subspecialists and primary care playing out?
Yeah, I just wanted to agree with Cathie. I think prospective payment, right, and financial accountability and appropriate compensation for that financial accountability are keys to the reimbursement model, the value-oriented reimbursement model, as Cathie highlighted. I think bundles, episode payments, right, are fraught with are extremely complicated to implement, and B, are fraught with conflicts. And I do think that there is a question here about whether or not, to Cathie's point, if cardiologists are acting as primary care physicians for a substantial proportion of their patients, whether the primary care prevalent model should also apply to cardiologists and at some level. And that's, that's something that I think is a whole different discussion, warranted, one that's warranted, but is a complicated issue to kind of unpack. In terms of, if we think just as, cardiology and primary care are separate, right, in the context of your question, Ed, I think putting value-oriented arrangements in place that create shared financial accountability and clinical accountability for quality outcomes and then total cost of care are going to dramatically improve care coordination. They're going to drive shared responsibility. They're going to force clinicians and managers of those clinicians to find ways to use technology, to use the available coordination mechanisms that exist in between those groups to drive more close alignment between primary care doctors and cardiologists. It's just it's a function of the payment model. So I'm a big believer in how value-based care will drive better alignment between primary care and cardiologists.
Great points. It's the accountable piece of the accountable care organization terminology. Before I ask Paul a question, just to remind everybody, if you have questions or issues that you'd like to have addressed, please put them in the chat so that we can get to those. Paul, I think one of the fallacies perhaps in people when they start talking about value-based care, it is something completely different from volume-driven care. But speak a little bit about to be successful in the value-based world, you still need to drive a lot of volume, right? I mean, it's still sort of success is driven by volume in that case. It's just not you're not being rewarded piecemeal for it.
Yeah, yeah, exactly. I think that's right. I think obviously, I think it's volume, but it's what is the quality of the volume, I guess, is what, right now. Goodness. If I see a patient, for a follow-up on hypertension, that's going to be reimbursed the same as if I see a complex heart failure patient in my office, right? But I don't need to see the hypertension. Likely the primary care can manage that, or they could email with questions. There's ways to manage it. So I think what we want to move towards is where the volume is really the appropriate patients that need the cardiologist's expertise. Mm-hmm. And we have, that's never been a incentive in the fee-for-service world, right? Because it's just volume for volume, not it's just any volume. So I think the move to value is really, and again, it gets to that point about the primary care and cardiology collaboration. And I think it has to be very deliberate in that some patients, clearly primary care can manage with a little bit of help from cardiology, and others require, cardiology to really be the primary care provider. And there's a continuum along that. And that has to be, as we think about that, be very intentional around like who's really most accountable on that or be attributed. So anyway, I think that, yes, I think it's volume, but I think it'll evolve to where patients who clearly need the expertise of cardiology.
So there are a lot of there's a lot of there in all of the things that we've been discussing. So I'm going to put Cathie on the spot a little bit here. Cathie, you're going to have sort of oversight for a lot of these things over the next couple of years here. What is the college doing, and what can the college do to not only prepare our members and physician members, but also the care team and our administrative colleagues? What are the programs that are currently in place, and what are some things that you think that we, other than obviously coming to the summit and coming to the Transforums, but what things does the college have in place to help us now, and what things do we need to develop further to meet this challenge?
Well, Paul and I talk about this all the time as to what's that secret sauce. And when do you start to cook the secret sauce? Because the summit, as we know, has been going on 18 years, and we probably have talked about the movement to value, 17 of those 18 years. And the problem I think you already identified, Ed, is people are expecting this tsunami to happen and to do something terribly different quickly. In reality, it's here. And we're living it every day. And we talked about at the summit, the fact that we're watching Medicare shift to Medicare Advantage. We're talking about what that means when they shift to Medicare Advantage, how it impacts the patient and the provider. So it's actually here. And I think the college, the continuation of getting the members involved in this, and we have to change the narrative, I think, because we've sort of designed it that it's something out in the future. And I think we've got to pull it back and say, it's really here right now. And for our CVT member, and we talked about it at the summit a little bit, how do you do in our financial model, how do you do team-based care that really delivers value? And how do you collect those outcomes that we're really looking at? And how do you get the outcomes to the physicians? We didn't ask the question at this summit, but if I had polled the audience and asked how many our interventional physicians had looked at their data, my guess would be pretty minimal. And finances too. What we need to do as administrators is get that data to you that align both your financial information and your CAP, PCI, and CDR information. And the college, I think, is helping move that along, especially with their alliance with MedAxiom. I think that the combination of the clinical guidelines and the financial component are really where we need to keep going. And then God bless our advocacy team, pushing for the different models to be developed, all the work Paul does with Pop Health. That has to continue and maybe even accelerate a little bit. But education, I think we need to educate differently to the reality, not to are we ever going to get to a prospective bundle? I don't think that's going to happen anytime soon unless Dan figures it out and, gets it all to us, but dealing with that.
Mm-hmm. Well, it's very interesting. I think, we are very much like the frogs in the pot and, being boiled. And when will we feel the boiling point? That's hard to know, but the process is happening, as Cathie intimated. I think there's a question from Joe Marine, which I think gets to a very important concept, and something that we try to hit home all the time is that the fundamental agreement is we have to have engagement of the physicians and all the care team members in this process in order to see success. But Joe's question is, how do we engage with membership on the transition to value-based care when we are so busy running on the hamster wheel for fee-for-service, pay-per-click practice? What is the hook, and or what is the again, things that the college can do, or what can we do in our health systems to help facilitate that transition? Dan, I suspect that's part of what you do in your day job, is
Yeah,
thinking about
yeah.
those things.
I mean, this is one of the key questions, right? I think I also just wanted to address. Again, there's so much to talk, so much ground. Like there's so much to talk about here and to think about. I think that before we move away, kind of from what Cathie talked about with respect to what we can do to prepare cardiologists for this future, I think, you know, the things that we do as cardiologists, right, and the data that we have access to through the ACC registries, you know, a lot of that is super valuable for thinking about quality of care for the things that we've spent a lot of time, particularly for procedural care, right, and things that a lot of us get trained to do. There is a bit of a, you know, there is still a bit of a disconnect there between what the data that we're focused on as cardiologists and the things that Medicare is really looking very closely at, right? If you look at the HEDIS measures that Medicare has outlined, which is a core Medicare Advantage, right, a core component of the STARS program, which is a big source of reward for Medicare Advantage health plans, and therefore a big source of reward for primary care doctors who are part of the Medicare Advantage program in terms of sharing risk. There are 5 of those metrics or so which are directly relevant for cardiology, right? Statin use in patients with certain types of illnesses, hypertension targets, you know, adherence to renin-angiotensin system inhibitors and statins and you know, a few other medicines. But beyond that, right, those are not, most of those metrics are not relevant for cardiology. Now, we haven't talked about how just focused on helping cardiologists to focus on how they can improve those core outcomes could be beneficial for cardiologists and could help them to engage in the prevailing value and payment model that Medicare has shown us is what it's, where it's, you know, where it wants to put a stake in the ground. So that's really important for us to think about, in addition to all of the other things that we do as cardiologists and that cardiologists do for their patients. To your point, Ed, about kind of thinking about how we, you know, how do we move the needle on these different types of payment models while we have day job, you know, while cardiologists have day jobs that require that they see 30 or 40 patients and you know, be in the cath lab for 12 hours a day. There does need to be some support for a transition period here, I think, right? And this is incumbent upon not just administrators and managers of hospitals and health systems. And you know, what I do with Novocardia is really to help support, or what we do, our team does, is to help support cardiology practices, to enable them to continue to deliver care to patients while we work with them on how their payment systems are designed, while we work with them to build better relationships with capitated or at-risk primary care groups, and start to put in place some transition from traditional fee-for-service towards more value-oriented payment models, including sub-capitation, right, or even global capitation. But there needs to be a support system in place so that clinical care can continue to be delivered. Patients don't suffer, right? It's not you're taking cardiologists away from doing what they have been trained to do and what we're good at and what we enjoy doing, but rather that you provide that additional layer of support for them so that that work can continue while the transformation work happens around them.
Fantastic. So, you know, we're having this conversation because we're in a state of crisis in that we have a ever-aging population. We have, you know, runaway healthcare inflation. We have huge governmental budgetary problems, deficits, and the projection for those to be even worse over time. And it's interesting that we probably have an opportunity to learn from our colleagues around the world, especially in low to middle income countries, who are recognizing these issues as here and now and how they're dealing with them, and the way they're dealing with them is really focusing upstream on prevention. And we've not had a good way of incentivizing prevention in our American healthcare delivery system. So maybe in the couple of minutes that we have to wrap up, we can get each of your thoughts in terms of where do you see, is this going to be something that's going to help us drive to that preventive mindset, and what will it take to get us to that prevention mindset successfully? So Paul, what are your thoughts?
So I just want to add one thing to your last question before I answer that one, if that's okay. Which is, sorry, it's like Dan, like there's so much to talk
I know
about.
this.
I just want to emphasize Cathie's point that value-based rate, whatever you want to call it, it is here now. It's not like we have to keep trying.
Right.
And I think our value-based care and cardiology forum that we do in December, tries to highlight that by saying how we can educate our cardiologists is to show them examples around the country where this activity is occurring, and how that's being done, what data is being shared, how it's working, because I think that's what resonates with clinicians is, we can talk about the theory, but they want to see, okay, I'm in fee-for-service now. Is this working anywhere? How is it working? And, I think we need to do more of that throughout the year, because I think that really is very helpful, including, as you may remember, at the forum, we had a very sort of thought-provoking, controversial presentation from Optum around their data and how they're using their data to drive or enhance the work of the primary care physician and cardiology, and but I think we need to talk about those things more and provide that to our cardiology members so they understand whether they agree or disagree or think there's a better way forward. Again, these examples about what's going on around the country from either the payers, from health systems, from others. So anyway, I just want to make that comment. So back to prevention. I think it's very hard to focus on prevention in the fee-for-service world. It's just the reality, unfortunately. And so I think, again, it gets back to if things move to these sort of larger, more comprehensive payment models, whether it's total cost of care models, capitation models, whatever you want to call it, and cardiology, and we figure out how best cardiology fits within there with the right financial incentives, then I think collaboratively with primary care, absolutely focusing on prevention will be important in the move towards value.
Cathie, how about what do you see especially in your current practices? Are they looking that far forward?
Yeah, you're probably not going to like this answer too much, because the reality is oftentimes I believe insurance companies may not want to practice prevention because sometimes it costs them more, and sometimes it costs them a lot more. And that is it's not even a secret anymore. So when people talk to me about prevention, absolutely hands down. But the only way we're going to keep moving is to align incentives. We've seen this over and over and over again. And unless we align incentives, we're not going to change the dime. And prevention absolutely belongs in here, but it doesn't get paid. And that's why we need to get to a much more value-based mechanism. And the MA plans pretend that they're paying for it, and the seniors, okay, wow, my teeth get covered, I get my meds taken care of, a life is good. My network is so narrow, however, that I really can't get some of the items that I need. So this goes beyond just physician education. It's sort of trying to turn the whole payer on its ears.
Yeah, I think if we're starting prevention at age 65, that's
a little late.
It's a little late in the game. Yeah, exactly. But your point about sort of aligning the incentives. So if the payers don't see an ROI on the preventive services. It goes back to the famous, the verapamil versus ablation for SVT. You can treat a lot of SVT with verapamil when you can cure it with ablation, but those are, two very different cost structures.
Yeah.
And if health plans are only typically engaged with a patient for on average 2 years, you're more inclined to use the verapamil.
Yeah, and just to go back to your point for a quick second, if you go, obviously younger than the Medicare population, many people are doing that. BMIs, no smoking, lower premiums, that's how to drive it, because you now have the items aligned with each other. It's fascinating to me when I watch this, however, because even though you have those financial incentives, it's still not enough to stop smoking or to get your BMI under control or your diabetes under control. So it's a cultural thing, I think,
Right.
as well.
Yeah, I just wanted
Go ahead. Go ahead, Dan.
no,
Sorry.
I just wanted to make one point, which is I think that we have to also define what we're talking about when we talk about prevention here, because I mean, if we're truly talking about preventing the development of illness, right? Preventing heart failure from actually developing, or preventing the development of ischemic heart disease. That has to start well before, as I think, you Cathie, you just, and Ed, you just noted, has to start well before people become Medicare eligible. If you're talking about preventing this, managing, doing your best to manage patients, whether or not they have disease, and prevent that disease from progressing, that's something that I think I do think that there are incentives, to try to prevent. And so and that's in general, I think that's work that many payers, again, with some exceptions, they're far from perfect. I'm not trying to argue that they're not focused on the short term, because in many cases they are. But I do think that there's an alignment there between preventing disease progression and preventing avoidable utilization from that disease progression, and some of the prevention work that many physicians find themselves trying to do but are struggling to do.
I was just going to add to this, sorry, Ed, because there's Julius Torelli put in the chat, what about secondary prevention, which I think Dan was getting at a bit. And, absolutely. I mean, Ed, you may have had a similar experience, as an interventional cardiologist. For years, you'd see the same patient coming back, yet for another stent. Right. You're like, and one of the reasons I sort of started to get more involved in population health was there's got to be a better way. I mean, it can't be that the cath lab is the answer, obviously. Right. And so there's so much more to do downstream, even after they've had an initial event.
Right. Yep.
So true.
Yeah, there are probably some who would make an argument that actually the most cost effective type of prevention is indeed secondary prevention, which gets back to the issue of identifying the people who are at highest risk and applying in a primary preventive standpoint. Preventing something in somebody where it's never going to happen is not very valuable. So it gets into this risk stratification, and precision medicine and things like that will upstream imaging, the imagenomics approach, the multi-omics approach will be something that will be quite interesting. So in the last couple of minutes that we have, maybe just some final thoughts around the subject of value. Cathie, you first.
Well, thanks a lot.
Yeah.
I think data, I'm going to go back to data again, and getting data in measurable, meaningful worlds, and also the education component that needs to start at home with that we're already here, and it's now. And then from a wider perspective, engaging our advocacy teams and such, and really trying to change the model. We've got to get these incentives aligned. 2030, if I have everybody in ACOs and Medicare Advantage, how have I really changed it if I haven't changed physician comp?
Dan?
I mean, I completely agree with Cathie. I think, at Novocardia, right, we are very focused on providing access to data at the point of care, and also on using advanced approaches for risk stratification and extending the bounds of the walls of the clinic right into patients' homes, so that we're delivering care not just via traditional mechanisms, which are really not always patient-centered, but also for appropriate patients in their homes and at other locations, so that we're managing and monitoring them kind of, you know, more consistently and continuously. So those are both, I think, very important features, I think, of the transition towards value-oriented models. The payment model is critically important too, and that has to get, we've got to improve how we reward clinicians for the care that they're delivering, if we are hoping to change how they deliver care, or at least to align by that I mean to align the payment model with the care delivery transformation. I would also say we have to be comfortable accepting incremental wins here, right? This is not, I think, Ed, you made the point that people are expecting some dramatic shift, right, that occurs overnight. I don't think that's wise from a quality standpoint. B, it's just not feasible. And so we have to be willing to accept, and actually excited to accept, incremental wins and celebrate those wins and recognize the progress that when it happens, so that people can start to feel the positive momentum if and when it occurs, because that's really, really important for galvanizing support and leading towards change.
Paul, final words.
I would say that I think we're at or very close to a tipping point when it comes to value.
Mm-hmm.
I think the downward pressure on fee-for-service will continue, not just for the federal programs, but importantly in the commercial programs, which often is priority for many in the health system level and certainly in the physicians. Mm-hmm. So I think with that, there's going to be continue more focus on the quality components in terms of payment as an interim. So I do think we are very close to a tipping point. And then the other comment I make, and I know you all know this, is that ultimately care is local. It's not going to look the same, you know, across the country, and that's one of the challenges. But to Dan's point, it's going to be incremental. There'll be certain places where this can be, the move can be more rapid, and, you know, you can see results. Again, having things in place, whether it's the data, the digital tools, the infrastructure, but it will be more challenging in some other, whether it's rural or other different types of systems. But that shouldn't hold us back. I think we have to learn from the places that are moving ahead, and then see how that can be applied to other areas of the country.
Well, to that end, I think you know, the classic image that's shown in many talks about talking about value and volume, the person with their feet in the two canoes. I think perhaps we're at the point where maybe we're at least lifting the foot out of one. We maybe don't have it in the other canoe all yet, and obviously our goal is to make sure we don't fall in the water as we do this very carefully and in a balanced fashion. So with that, I'd like to wrap up and again thank our guests, Dan Blumenthal and Paul Casale, and always thanks to Cathie Biga. This was hopefully this discussion of value was of value for those of you who have participated. So thanks again for being here, and we look forward to seeing you in a couple of weeks at ACC 23, just to be together, and also we will have another installment of UnEDited at that time talking about global health issues. So thanks again for being here today. Everybody be safe.
Have a good weekend.
Yeah, thank you.
Thanks very much.